hypoglycemia is a common presentation, one which is often missed. And in the case of hypoglycemia, often we may not be able to reach a diagnosis, and that may have a lot of disastrous consequences from these hypoglycemic disorders, and we'll carry forward from that perspective. Uh, you can all go and have a look at our website, where has got a lot of information, including resource in pediatric endocrinology, e-learning platform, our courses which are there, including fellowship and pediatric endocrinology programs, our grand rounds, our journal clubs, and other activities which regularly happen, our books which are available both online as well as the hardbound version, our mobile application which guide. When you talk about glucose homeostasis, we are basically looking at in terms of how the glucose comes in our diet, it is absorbed via the intestine, and then it is used predominantly via the brain, the muscle. These are the major usage organs as far as that. And then if you have extra amount of glucose, it is stored in the liver. So liver is like your bank where you store all your glucose in the form of glycogen. Now, this glucose can also be stored in the kidneys as glycogen, and it is then excreted there, which is prevented via the SGLT2, which we know all that. So, if there is a problem either at the level of feeding, problem at the level of glycogen storage or glycogen release, problems of glucose may be happening. Once you are fed and your glucose becomes more, it can be utilized via the brain, and then you will have this glycogen is providing you as a store in that perspective. So if you have problems in the glycogen synthesis or glycogen release, you will be if you have a problem in glycogen synthesis, of course you can't have enough glucose in the liver. So you will have, it's like somebody who doesn't have a bank account. When they eat, their sugars will become very high. And then when they starve, they will have no backup, they will become broke. So you will have fasting hypoglycemia and post-meal hyperglycemia. That is your typical presentation of two conditions, GSD0, which is glycogen synthase deficiency, or GLUT defect, in which the glucose is not being transferred. If there is a problem in the glycogen release, what's happening? You have deposited your money in the bank, and suddenly your ATM card is not working. So you have got a lot of money, but you cannot utilize it. You start using your alternate resources from that perspective. Now, kidneys can also produce glucose through gluconeogenic pathway, which is through fructose and other pathways. And when you have lost everything, the final reserve is, so if you have taken off all your bank account, you have sold all the ornaments, what is left? Property. You will sell the property. So fat is like your property, which the body uses as an alternate source. It burns the fat to produce ketones. So these are the defense mechanism. The first is whatever money you are making every day, that is surviving, that is like what you're eating. Second is you use your ATM to get food from the glycogen. Third is you're using all your money which you had stored in the form of some ornaments like gluconeogenic defect. And finally, you are selling your property to survive, which is your gluconeogenic, in which you're using your protein and fat to produce glucose. So that's the last thing the body wants from that regard. Now, we are mainly focusing about glycogen, so I'm not going to talk about other pathways. But remember, glucose is to be sent into the liver using GLUT2 and glycogen synthase and brancher. So glycogen synthase will add glucose to the glycogen, and they will be branched using the brancher enzyme. Now, this glycogen can then be really converted into glucose using debrancher, phosphorylase, and glucose 6-phosphatase. The most important enzyme of the carbohydrate metabolic pathway is the glucose 6-phosphatase, which is the common point for both the glycogenolytic pathway, the gluconeogenic pathway, the galactosemia pathway. All of them converge at the level of glucose 6-phosphatase to release glucose in that regard. Now, of course, pancreas produces insulin, which will try to store the glucose as glycogen. So it will increase the glycogen synthase and brancher activity, and it will inhibit the debrancher activity, which will release, so it will cause storage of glycogen. That is why hyperinsulinism, you will have hepatomegaly because of glycogen storage. Glucagon has got a lot of effects, but the major effect of glucagon is glycogenolysis. So it is going to release your glucose from that perspective and produce more glucose. Now, glycogenolysis is the process in which glycogen is broken down into glucose. The three major organs where glycogen is stored is the liver, the kidneys, as well as the muscles where it will be stored. It is converted via phosphorylase and phosphokinase to limit dextrin. What do you mean by limit dextrin? It is the point at which the branch comes. Once the branch comes, they cannot convert glucose. From the limit dextrin, you need debrancher enzyme, which produces glucose 6 phosphate, which is converted via glucose 6 phosphatase into glucose. So, if you have a problem in the glucose 6 phosphatase, nothing will be produced. If you have a problem in the debrancher, you will have some production, but then after a time, you will not be able to produce glucose. If you have a problem in phosphorylase, phosphokinase, it will be even more. So the gap between feed and hypoglycemia will be the maximum for phosphorylase, phosphokinase, followed by debrancher, followed by glucose 6 phosphatase. So those conditions present more as a storage disorder, as hepatomegaly, liver dysfunction, and problems of myopathy, pain, exercise-induced problems, and all those things will be more likely. Now, as I said, glucose 6 phosphate is a common site. It is also being produced via the fructose 1,6 bisphosphatase. All the gluconeogenic pathway will also converge out there. It's like a confluence. So this is basically coming from lactate to pyruvate, which is then getting converted into glucose 6 phosphate. So now what I was talking about, if you have a problem in glucose 6 phosphatase, you will have a back effect. If you have a problem in fructose 1,6 bisphosphatase, you will have a back effect towards lactate. So only two conditions lactate will go up. In debrancher problem or phosphorylase phosphokinase, which is GSD 3, 6, and 9. This is what we talk about as milder forms of GSD. You will not have high lactate because lactate is not in their path. So this becomes important to understand. Now, galactose is converted to galactose 1 phosphate and then again via the same. So it's like a three confluence, Triveni sort of a scenario. All three are getting mixed up here. And the most important point there is glucose 6 phosphatase. So if you have no glucose 6 phosphatase, there is no way your body is going to get glucose. You need to feed every 2 hourly. That is the big message from that perspective. So this provides backup in infants for 4 hours. So when I say 4 hours, that infant may not have fed for 4 hours, and that's why hypoglycemia happens. And then somebody is not feeding enough, you may present early. That's less likely, but it can. In childhood, it will be 6 to 12 hours, and then the issues would be there. Now, the second backup, which we are talking to discuss about, the second condition which you presented is gluconeogenic defect, which means production of glucose from alternate sources. So this is the last ditch effort. Everything is gone. You are selling your home to get the glucose. So your building blocks of the body are amino acids. You're breaking amino acids. So lactate and alanine are converted to pyruvate, which is converted via carboxylase to oxaloacetate, then pep carboxykinase to pep, and then fructose 1,6 bisphosphatase to, again, you get fructose 1 phosphate, and from there you get the glucose 6 phosphatase, which is working from that perspective. The fructose 1,6 bisphosphatase is also important because it is also the point where your fructose and glycerol come into the picture. So here you are linking your fatty acid oxidation, you're also linking your fructose to produce glucose. That is why Alappan was talking about that you should not give too much fructose. If you give them too much fructose, what is going to happen? You will have accumulation of other things, but not production of glucose. This is something important in this particular effect. And then finally, you have got glucose 6 phosphate, which is converted into glucose. Now, fructose 1,6 bisphosphatase is the most severe form of gluconeogenic defects. There are other forms also like pep carboxykinase or carboxylase, which are milder. They will not have that many features and they will have milder lactate elevation. But yes, they can have, but they typically will present with other features. Gluconeogenesis provides backup for 12 to 24 hours in that perspective. Now, which hormone regulates which becomes important to understand. Insulin is a hypoglycemic hormone. So it will decrease glycogenolysis, decrease gluconeogenesis, lipolysis, and ketogenesis, everything. Your glucose will come down. In fact, it will promote your glycogenesis, it will promote your ketogenesis, it will promote your fat formation, and other things will be there. Epinephrine has got a major effect on glycogenolysis and ketogenesis with milder effects on other perspectives. Glucagon mainly works in the setting of glycogenolysis as well as gluconeogenesis, and growth hormone will clearly have a major effect on lipolysis. That is why individuals who have growth hormone deficiency look chubby or fatty in that perspective. And cortisol has a major effect on gluconeogenesis. But so there are four hormones which are regulating the counter regulatory process. There is overlap. You can't just say that it's only that, but predominantly you can say that glycogenolysis is a glucagon phenomena, lipolysis is the growth hormone phenomena, gluconeogenesis is the cortisol phenomena from that perspective. So anybody who is fasting should have a glucose which is less than 50 milligram per DL. Insulin should become undetectable. Cortisol level should be above 550. Growth hormone should be more than 10. But sometimes these counter regulatory, if they are long term deficient, may not be that low. So then you can have some exhaustion which may happen from that perspective. Now, other scenario would be your glucagon should be high. So giving extra glucagon should not increase your level of glucose with the exception of hyperinsulinism. So that is something to remember. Glycogen problem happens at 6 to 10 hours. Gluconeogenic pathway problems happen at 10 to 24 hours. And then subsequently, other parameters will be ketotic pathway will be 12 to 24 hours, which will give you a picture. If you give glucagon, there will be no increase in glucose. If you, in fact, have a glucose 6 phosphatase defect, the lactate will increase in a fed state. So glucagon test is a way to differentiate gluconeogenic defect from fructose 1,6 bisphosphatase deficiency in that regards. So all processes are important. At 6 hours, you can see 90% is glycogenolysis. As you go from 12 to 24 hours, the glycogenolysis becomes less. The other pathways become important. So timing and gap between meal becomes a very, very important process to understand from that perspective. So we'll go one by one. So glucose 6 phosphatase defect, the problem is at the confluence of all the three pathways. So you will have no glucose production. Glycogen is going to be stored in the liver. Fructose is not working, galactose is not working, so glucose is not going to increase from that regard. More glycogen will basically mean it will be accumulated in the liver and in the kidney, causing hepatomegaly and renomegaly. You will have high level of cortisol, epinephrine, growth hormone, all the counter regulatory hormone will be more. Ketosis will be there because you will produce ketone. Triglyceride will go up because of all these counter regulatory hormones. Uric acid will go up because of the the action through that pathway which becomes activated. So you will have hypertriglyceridemia and high uric acid which is there. Glucose level will not increase after giving glucagon. You will in fact have a paradoxical rise in lactate which will happen with glucagon injection. The GSD basically is two types, GSD1, which is basically a defect in glucose 6 phosphatase with defective glycogenolysis, defective gluconeogenesis, presenting onset is 4 to 6 months with hepatorenal high lactate ketone and glucagon. GST1, 1B is actually a problem in the glucose 6 phosphatase transporter. So the enzyme is not defective, the transporter is defective. And in this scenario, the problem is similar to GSD1 with the exception of leukocyte dysfunction. So this case which Alapan discussed has a GSD 1B which is there. The manifestation again is later, but you may have an earlier presentation. There is a greater predisposition to autoimmune disorders and infections in that regards. Now in debrancher activity, GSD3, you will have some production of glucose, but after the branch comes in, you will not be able to produce. You will have accumulation of limit dextrin. It has a delayed onset with hepatic dysfunction. This is a major presentation which will happen. And there will be myopathy because muscles also need a lot of glycogen to provide us with the energy levels in that regards. So GSD6 and 9, they have a problem in phosphorylase kinase, which is a terminal defect. Manifestation is late with growth failure and myopathy. I have seen patients with these forms of GSD referred mistakenly as growth hormone deficiency because they'll be short, they'll be plump, they will be chubby, and that's why they are labeled as GSD. But in fact, they will have huge liver, and you can identify that in that regards. What is GSD 0, Dr. Sandeep?
The GSD0 is due to glycogen synthase defect.
Okay, yeah. What happens there?
In this, there will be no production of glycogen in the liver, and there will be a deficiency of glycogen, so there will be no hepatomegaly.
So is this really a GSD?
This is basically not a GSD. It's a misnomer.
So in a classical sense, it's not a GSD, but it's a problem in glycogen metabolism. So classically, as you said, the problem is in glycogen synthase. Synthesis does not happen. You will have fasting hypoglycemia. You don't have any bank account. So when you need, you will not get the money. But whenever you get your salary, everything is overflow. So you have post-meal hyperglycemia. So this is a paradoxical response which happens in the setting of a hypoglycemia followed by hyperglycemia. And this is a close differential of ketotic hypoglycemia. In fact, the recommendations are if you're labeling somebody as ketotic hypoglycemia, you in that scenario give them glucose and see if they become hyperglycemic. That is important to remember. Now, GLUT2 or Fanconi-Bickel syndrome is again an important scenario in which you will have a problem in the renal and hepatic transport. You will again behave like GSD 0. So again, 6-month onset fasting hypoglycemia, post-meal hyperglycemia. We have seen patients who are presented more with renal abnormalities in the form of Fanconi syndrome like that, but they can also have hypoglycemia, which is their RTA and glycosuria. Finally, the gluconeogenic defect, the problem is at the fructose 1,6 bisphosphatase or of course pepcarboxykinase and carboxylase. Here you will have no production of glucose which is happening through the alternate pathway, so it will be later onset, typically after 1 year. So this case presented 16 months. This is the typical presentation which is happening. Your lactate will be high in fructose 1,6 bisphosphate deficiency, and you will have ketone which will be present. There will also be no increase in lactate after glucagon. So why do you think this happens? How is it different from GSD1 then? Why in gluten?
Why lactate is not high?
Yeah.
Uh, because in gluconeogenic defect, if there is no accumulation of the lactate in the previous part. So
you have accumulation of lactate,
but it is a little amount than.
So compared to GSD1, you will have much more amount there in GSD1. Here it will be much lower. But of course, lactate is high in the basal state, but fed state giving glucagon does not increase. The fructose 1,6 bisphosphatase deficiency, the defect is onset after 12 months with high lactate and acidosis. It's a life-threatening condition. So if you now summarize the condition, enzyme defects, of course, GSD1 is glucose 6 phosphatase with massive hepatomegaly. You will have high levels of lactate onset at 6 months and they will develop hepatic adenoma. GSD3 is a problem of debrancher. GSD6 or 9 is phosphorylase or phosphorylase kinase, large liver. But their lactate will be normal. Onset is typically 12 months and you will have myopathy and transaminitis as a major presentation. GSD0 will have no hepatomegaly and they will have hypoglycemia, which is basically having prandial hyperglycemia. Gluconeogenic defect is fructose 1,6 bisphosphatase, where you have massive hepatomegaly with high lactate after 1 year. That is the diagnostic feature. So identifying this glycogen storage disorder is very important because it's not just about glucose. They have so many other metabolic defects. They have got dyslipidemia, they have got liver dysfunction, renal dysfunction, RTA, muscle problems. So this can be a big problem, and all you can do, if you give them periodic glucose, you will improve. Now that is, you can all go and have a look at an app which also has a hypoglycemia interpreter which will help you reach the diagnosis, our courses as well as our platform.